Welcome to The Healthy Rendezvous, the podcast that breaks down complex health topics. I'm your host, Dr. N. Today, in our segment Inside the Pelvis, Guts, Hormones, and Truths, we're diving into a subject that affects millions, but is often discussed only in whispers, infertility. And to guide us through this, I'm thrilled to have an expert with us, Ob-Gyn specialist, Dr. Liza. Welcome to the show.
Thanks for having me, Dr. N. It's a really important topic, and I'm glad we're talking about it openly today.
Absolutely. So let's start with the fundamentals. I think a lot of people think they know what infertility is, but from a clinical standpoint, how do you actually define it?
Clinically, we define it as the inability to get pregnant after 12 months of regular unprotected intercourse, but honestly, that definition barely scratches the surface.
Right? Because it's not just a medical term.
Exactly. It's not just a diagnosis, it's a complex mix of biology, timing, expectations, and often a whole lot of stress for patients. And it's also really common.
How common are we talking?
Globally, somewhere between 8 to 12% of couples are affected. Here in the US, it's even more prevalent. Over 12% of reproductive age women have sought infertility care at some point. So, this is something we see all the time, even if it's not always talked about.
That's more than 1 in 10 women. It's staggering. I imagine that silence contributes to a lot of myths and misconceptions. What's the biggest one you encounter?
Without a doubt, the biggest misconception, and I see this constantly, is that infertility is mainly a female issue. It's not.
Okay, that's huge. Let's unpack that because I think it's the default assumption for many.
The causes are actually pretty evenly split. Female factors account for about 35 to 50% of cases,
35 to 50.
and male factors account for about 40 to 50%.
So it's essentially a coin toss. It's just as likely to be a male factor as a female one.
Exactly. And then there's this big category of unexplained infertility, which can be up to 30% of cases. So, right from the start, we have to approach this as a shared issue. The evaluation really has to reflect that.
That's a critical mindset shift. So, after understanding it's a shared issue, what's the next big concept for couples to grasp? You mentioned timing earlier.
Another really important piece is timing. When do you actually start worrying? And when do you start working things up? For patients under 35, we usually say try for 12 months before doing a full evaluation.
Okay, so the 1 year mark we discussed in the definition, but I hear that number 35 is a major line in the sand. What happens then?
It is. Once you hit 35, that window shortens to 6 months.
Wow, it cuts in half. And what about for women who are even older?
If someone is over 40 or has known risk factors like irregular periods, known endometriosis, or prior pelvic infections, we don't wait at all. We start evaluating right away.
So the urgency really increases with age.
Absolutely. And that's really driven by the age related decline in fertility, especially ovarian reserve. Time matters a lot more than people realize.
So, a couple comes into your office. They've crossed that time threshold. The whole process must feel incredibly overwhelming. Where do you even begin?
Even though it can feel overwhelming, the way we approach infertility is actually very structured. The questions we're trying to answer are pretty straightforward.
That must be reassuring to hear. What are the core questions you're looking to answer?
There are four main pillars to the evaluation. First, is ovulation happening? Second, is the anatomy normal, meaning the uterus and fallopian tubes? Third, what is the ovarian reserve? And fourth, is there a male factor?
Okay, ovulation, anatomy, ovarian reserve, and male factor. Let's take those one by one. How do you determine if a patient is ovulating?
Starting with ovulation, one of the simplest things we look at is menstrual regularity. If someone is having regular cycles, that's reassuring. But to be sure, we can confirm ovulation with a progesterone level in the mid-luteal phase, usually around day 21 of the cycle.
And if that progesterone is low?
That suggests they're not ovulating, and ovulatory dysfunction is actually one of the most common causes of infertility.
What typically causes that?
The biggest culprit here is polycystic ovary syndrome, or PCOS. But we also think about thyroid disease, high prolactin levels, hypothalamic issues, and even lifestyle factors like significant weight changes.
Okay, so that's pillar one, ovulation. What about the second pillar, anatomy?
Then we move on to anatomy. We want to know if the sperm and egg can physically meet. For that, we typically use ultrasound to look at the uterus and ovaries, and a test called a hysterosalpingogram, or HSG, to check if the fallopian tubes are open.
A hysterosalpingogram. That sounds intimidating. In simple terms, what does that test involve?
It's essentially an X-ray with dye. We inject a special dye into the uterus, and if the tubes are open, we can see the dye spill out into the pelvis on the X-ray images. It's a very effective way to check for blockages. Tubal disease is a big one, especially in patients with a history of pelvic infections, sexually transmitted infections, endometriosis, or prior surgeries. Even subtle scarring can make a big difference.
Got it. So, after anatomy, the third pillar was ovarian reserve. What does that tell you?
Ovarian reserve is really about the quantity of eggs, not necessarily the quality. We use markers like anti-Mullerian hormone, or AMH, FHH, and an antral follicle count done by ultrasound.
AMH is one I hear about a lot now. Why is it so useful?
AMH is particularly helpful because it's a simple blood test that doesn't depend on where you are in your menstrual cycle. But there's a really important caveat here that I always try to explain to patients.
And what's that?
Ovarian reserve tests don't necessarily predict whether you can get pregnant naturally. They're more helpful in predicting how you'll respond to treatments like IVF. Still, they give us a sense of how much time we may or may not have.
That's a crucial distinction. It's a planning tool, not a crystal ball. That brings us to the fourth and final pillar, the male partner.
This is huge and honestly sometimes underemphasized. The first step is a semen analysis. It's relatively simple, but gives us a lot of information: sperm count, motility, which is how they move, and morphology, their shape.
And if you find abnormalities there,
They can be due to a range of things: hormonal issues, genetics, environmental exposures, or lifestyle factors like smoking, alcohol, or obesity. So, again, this is very much a two-person evaluation.
so you go through this entire systematic four-part evaluation. What happens when everything comes back normal?
That happens quite often. We often end up with couples where everything looks normal, ovulation is happening, tubes are open, semen analysis is normal, and yet they're not getting pregnant. That's what we call unexplained infertility.
That must be incredibly frustrating for patients to have a problem with no clear cause.
It can be really frustrating because there's no clear answer, but it's also very common and it really shapes how we think about treatment.
Let's talk about treatment then. Once you have a diagnosis or even a non diagnosis like unexplained infertility, how do you decide on a management plan?
Management depends on what we find, but also on the patient's age and their personal goals. For ovulatory issues, we often start with ovulation induction.
What does that involve?
We use medications like clomiphene or letrozole. Clomiphene works by essentially tricking the body into thinking estrogen levels are low, which stimulates the brain to release more follicle stimulating hormone, or FSH, and that leads to ovulation.
And letrozole, does it work the same way?
Letrozole works a bit differently by lowering estrogen production directly. And interestingly, it's actually been shown to be more effective in certain groups, especially patients with PCPO.
Okay, so that's for ovulation. What about the other issues like the anatomical problems we discussed?
If there are tubal issues, sometimes surgery is an option, but more often we move toward IVF, since in vitro fertilization bypasses the tubes entirely. For uterine issues like fibroids or polyps, those might need surgical correction if they're in a place that could affect implantation.
And for male factor infertility?
Depending on the severity, we might use intrauterine insemination or IUI, where sperm is placed directly into the uterus. Or we might use more advanced techniques like ISEI, intracytoplasmic sperm injection, which is done as part of an IVF cycle.
Beyond these medical and surgical treatments, how much of a role do lifestyle factors play?
Lifestyle plays a bigger role than people expect. Even modest weight loss, like 5 to 10%, can improve ovulation and pregnancy rates in patients with obesity.
That's significant for such a small percentage of weight loss.
It really is. Diet, smoking, alcohol, and even marijuana use can all impact fertility in both partners. So these are things we always address alongside any medical treatment.
This is a great overview of the whole process. To help our listeners really understand how this plays out, can you walk us through a real world example? Beyond the medical treatments and lifestyle changes, there's a huge emotional component to this journey that we haven't touched on yet. What kind of psychological impact does a diagnosis of infertility typically have on individuals and couples? This is a great overview of the whole process. To help our listeners really understand how this plays out, can you walk us through a real world example?
Of course. To Bring this into a real clinical context, there was a recent case published in the New England Journal of Medicine that I think illustrates this really well.
Okay, what was the situation?
It's a couple where the female partner is 36. She has regular cycles. They've been trying for a year, and everything in the initial evaluation comes back completely normal.
So, this is that classic unexplained infertility we just talked about. 36 years old, 1 year of trying, they are right at that decision point.
Exactly. At that point, you have a few options. You could continue trying naturally for a bit longer. You could do ovulation induction with intrauterine insemination, or you could move to IVF.
What did they choose and what drove that decision?
In this case, the decision was actually driven by something very practical. The couple wanted 3 children.
Oh, that's interesting. So, it wasn't just about getting pregnant once, but about their long term family building goals. How did that change the plan?
Instead of taking a stepwise approach, they went straight to IVF. And the reason is that IVF doesn't just help you get pregnant now, it allows you to create embryos and preserve them for the future.
Right. So they're essentially banking their future children, using her eggs at age 36, even if they don't try for a second or third child until she's 39 or 40.
Precisely. So in their IVF cycle, they retrieved 13 oocytes. 9 of those fertilized, and 6 developed into high quality blastocysts.
Wow, 6 high quality embryos. That's a fantastic outcome.
It's a really good outcome. They transferred 1 fresh embryo and had a successful pregnancy. And now they have 5 high quality embryos frozen for future use. This significantly increases their chances of achieving their ultimate goal of having multiple children.
That's incredible. It really highlights a shift in how we think about these technologies.
I think this really shows how IVF has evolved. It's not just a last resort anymore. It's increasingly being used as a strategic tool, especially for patients who are thinking about long term family building. It allows us to separate the timing of embryo creation from the timing of pregnancy, which is a big deal when you consider how quickly fertility declines with age.
This has been so enlightening. As we wrap up, what are the main takeaways you want our listeners to remember when they think about infertility?
When you step back and look at everything, a few big themes stand out. First, infertility is common and it's shared between partners. Second, the evaluation is systematic. We're not just ordering random tests, we're answering specific questions. Third, age is probably the single most important factor guiding management. And finally, even when everything looks normal, unexplained infertility is still very real and very common.
And it seems the approach to treatment is also evolving.
And maybe most importantly, the way we approach treatment is changing. It's becoming less reactive and more proactive. It's more tailored to the patient's long term goals rather than just the immediate diagnosis. Because at the end of the day, infertility care isn't just about getting someone pregnant, it's about helping them build the family they want in the most effective and thoughtful way possible.
Proactive, thoughtful, and goal oriented. That's a powerful and hopeful note to end on. Dr. Liza, thank you so much for sharing your expertise and clarifying such a complex topic for us today.
It was my pleasure. So thank you for having me.